Okay, I guess we should begin, and I want to welcome everybody to the Wednesday evening webinar. And this evening we have a very interesting lineup. We have three contributors who are looking to the future of surgical teams. Professor Lisa Alexander, who is the director of the Physician Associate Program here in RCSI. Lisa joined us in 2020 from the United States, where she had extensive experience in PA education. And I think PAs are a new professional body of healthcare workers that are really going to be transformative in terms of the delivery of surgical services. We are delighted to have Sarah Casserly-Feeney, who's the lead physiotherapist for the planning and performance in the National Musculoskeletal Triage Initiative. And Sarah, we're looking forward to hearing how the physiotherapist of the future is going to be integrated into the surgical team. I'm sure it's well advanced in musculoskeletal practice and maybe not quite as integrated in other surgical services, but we look forward to hearing from you. And then Jamie Logan, who is the nurse lead in the National Clinical Program in Surgery. Jamie, you're very welcome, and you're going to talk to us about advanced nurse clinical practitioners and their role in the surgical team. I think there is no doubt the surgical team is going to be very different in the next couple of years, and it'll be all the better for it. And all of us who have worked with clinical nurse practitioners, who've worked with PAs, as I have in the United States, or have worked with specialist physiotherapists who are integrated into the team, we all know the insight they bring and the benefits they bring to the workings of the team. So we're going to start with Professor Lisa Alexander, who's going to talk to us about the impact of physician associates are having on surgical care. And Lisa, we look forward to your presentation. Thank you.
Thank you so much, Professor O'Connell, and it's my pleasure to be with all of you this evening. As you've heard, my name is Lisa Alexander, and I am the director here at RCSI of the PA program. And it's my pleasure to be with everyone this evening. Now, the next slide just gives you a sense of what we look like at this point in time. So this program started in 2016, and we have grown, I think, strategically and intentionally, but I'd call it smart growth. But this program right now is looking to enroll its next cohort in January, but this photograph here represents our first and second year classes who were on campus recently for a callback day. So it is our hope to have a much larger cohort in January of 2022. Right now we average about 15 students per cohort, and we're looking to expand at least to 20 in 2022. Next slide. This is an outdated slide as things are evolving quickly here in Ireland as it pertains to physician associates. We have the majority of graduates working in the Dublin area. However, slowly but surely we're extending our footprint across the Republic. And as you can see on this slide, we have a number of students, or graduates I should say, working in Galway, Waterford, Cork, Navan, and we understand in a very short period of time in Drogheda, one of our colleagues, Professor Al-Masri, he is looking to hire 2 PAs for his surgical assessment unit. So as you can see, we are expanding outside of our Dublin footprint. Next slide. So I just wanted to provide a brief background of PAs in surgery in the United States. Which I'm familiar with. My first position as a PA was working in orthopedics and neurosurgery. It's a very large workforce in the United States right now. PAs have grown significantly over the last 50 years. And right now, the latest data shows us that about 20% of all PAs, so we number about 140,000 PAs across the United States, but about 20% of all PAs are working in surgery. And as you can see in this slide, these represent the most popular subspecialties in the surgical area. So orthopedics, general, and cardiothoracic are the top 3 fields that you will find the majority of PAs working. Next. And this is a slide taken from the Faculty of Physician Associates in the United Kingdom in collaboration with their home, if you will, in the Royal College of Physicians. And this speaks to the role of PAs and what they can bring to the surgical ward. And one of the things that resonates with me is this notion of continuity of care. PAs can often be the glue that sort of holds the team together, if you will. They are very effective in their role in making sure that, sort of the things don't fall through the cracks. And oftentimes in training rota, we see a change in staff that can compromise the quality of care. And PAs have found themselves to be very effective in providing that continuity across different services, and helps to, I think, maintain a high level of communication, as well as ongoing research projects, audits, rota management, a variety of different things. So the PA role emerged in the United States during the time when residency work hour reductions were implemented. And this is one way that PAs have shown themselves to be very flexible in how they're deployed across various workplace settings, and surgery is definitely no stranger to that particular phenomenon. The next slide. I wanted to just show this to you because in our discussions this evening, we talk a lot about sort of that surgical package, if you will. And this is a slide that comes from a study on the cost effectiveness of PAs in orthopedics. And when in the United States, with, as you know, the sort of financing of healthcare is somewhat different than it is here, but they've broken down the costs for each procedure based upon, this is data coming from the Centers for Medicare and Medicaid Services, but they talk about the global surgical package. And this is not the international surgical package. This means the comprehensive cost or the totality of costs that are associated with surgical procedures. And as you can see, 69% of those costs are tagged to the intraoperative procedure itself. But there are so many other costs and roles for the healthcare team. So it's about a 30 to 70% ratio for costs that are incurred preoperatively and postoperatively. So when you think about the variety of healthcare practitioners that are part of the surgical team, this does a nice job of allocating really the cost effectiveness of PAs in the surgical area. Next. I'm afraid this slide might be very small for attendees, but it essentially would is data that is provided by the National Certification of Physician Associates in the United States. And it asks the services that are provided and how frequently they're provided for patients in, or for practitioners in the provision of surgical services. So as you can see, the scope of roles and the practice of PAs in surgery goes all the way from conducting the preoperative physical exam, obtaining the histories, ordering and interpreting pre-op lab works, all the way down to making referrals, diagnosing, and treating. So these are just the spectrum of services provided by PAs to the surgical team in the United States. So next slide. So as I transition to the next speaker within my allocated period of time, I thought it would be helpful for those of you to hear from one of our recent graduates who's working in the surgical area down in Cork. And but before I introduce him, here's my contact information. Should anyone have any questions about our program or the profession, thoughts about potential applicants that would be suitable for our program, advocacy, student placements, or any research interest that you have, my contact information is there, and I would welcome any opportunities to collaborate with you. Next slide. So Aaron Brady, as I said, is a recent graduate of our program, and he was our top student. I'm telling you something that he probably would be too humble to admit, but Aaron is currently working at the Bon Secours Hospital in Cork in the area of general endocrine and breast surgery, and it's my pleasure to ask Aaron to share with you his observations and insights as a new graduate working in the surgical team. Aaron?
Aaron, you need to unmute yourself there. Good, great.
Yeah.
Thank you.
Thanks very much for that introduction, Lisa. As Lisa already mentioned, my name is Aaron Brady. I graduated from RCSI last month with a degree in Masters of Science in Physician Associate Studies. I suppose I'll just give you a tiny bit of my background before delving into my current role in Cork. I initially graduated from UL with a degree in general nursing. I then went over to the UK and I specialised in intensive care nursing, and I worked as an ICU nurse for 7 years, both between the NHS in the UK and then the Mater University Hospital in Dublin. I then commenced my PA programme back in 2019, and I recently graduated. I started my position with consultant general breast and endocrine surgeon Mr. Peter O'Leary down in the Buns Hospital Cork about 8 weeks ago. So my role kind of has three main aspects to it. So there's a clinical, a surgical, and a research aspect to it. From a clinical perspective, I'm responsible for running Mr. O'Leary's service on a day-to-day basis. This would involve conducting daily ward rounds, reviewing the patient's history, performing physical exams, reviewing the current blood work, and the scan results. And from there, I'll kind of develop a management plan in conjunction with Mr. O'Leary, and my kind of role is in ensuring that the aspects of the care plan are kind of carried out in a timely and efficient manner. I'm also then responsible kind of for following up on say scan results that were carried out that day, and from there then I play a key role in discharging the patients. I know from kind of audits completed in the hospital, there's one area that I've been kind of targeted towards improving is the discharge times and getting patients out in a timely manner in order to create more space for further incoming patients. Also, in terms of clinical work, I'm responsible for dictating all the discharge letters. From a surgical perspective, I kind of started off as second assist, and slowly but surely I'm kind of working towards becoming first assist. They're putting me on training programs to work in both open and laparoscopic surgeries. This does include kind of camera work. In time, I'm hoping to progress clinically in order to kind of close wounds. Another aspect of the job would include kind of research. So I'm trying to get ethical approval for a retainer study at present, which is looking at the rate of acute urinary retention post inguinal hernia repair, which I believe is a study. It's going to run from the RCSI. So that's something I'm very interested in pursuing, and there's many more research opportunities down in the bonds. I suppose as the future of the role is bright. Since starting, there's a great amount of interest amongst many consultants within the hospital for bringing in PAs in order to, like Lisa mentioned, increase team efficiency and the aspect of continuity of care. I know from a private hospital setting, There's no real kind of defined team, so there's a real kind of niche there that a PA could fill and make a big difference. In terms of my personal kind of professional development, I'm kind of looking towards hoping to get into a kind of education role. Hopefully, if further programs open up in the future, I could act as a clinical tutor down in Cork. And hopefully with the assistance of regulation, our role can expand further. That's kind of it for my role for now. I'm new to it, so the role is evolving. And as I gain more experience, I think my clinical responsibilities will grow too. So it'll be certainly exciting to see the profession grow, and I'm glad to be a part of it. Thank you.
Many thanks, Aaron. It certainly seems that you're enthusiastic about your new role and that you've been enveloped into the team and welcomed in the team. Aaron, you're working in the private sector. Are there residents, SHOs or interns associated with the team as well?
Yeah, so they've kind of 5 surgical interns. They're not specifically assigned to a specific consultant. So as such, a consultant doesn't have anyone on their teams. I think the interns play a role in discharging, but they'll discharge for many different consultants across many different surgical specialties. So in terms of improving specific team efficiency, it's not really working well from that perspective because, like I said, they're not specifically assigned to a consultant. There is registrars, all right, and they work mainly in theatre, and then they do on call to admit acute admissions or if there's any deterioration in the ward. But again, they're not specifically assigned to a consultant, so there's no real continuity in terms of workers within the medical and surgical teams.
And we've just something in from Paul Balfe, who's a surgeon in Kilkenny, says you sound very much like a surgical SHO, and and maybe Lisa would come in. Do you think a PA will replace the senior house officer in HSE hospitals?
We're not here to replace. I think it's important to note. We're not here to replace doctors or advanced nurse practitioners. We're designed to complement the already existing team that's in place. And as the saying goes, many hands make light work. An additional member to the team who has a broad range of clinical skills and knowledge can improve that team efficiency. And the main thing is that the patients receive top quality care. And I think a PA can be a key member in delivering that.
I think that's a very mature and thoughtful answer, and I suspect you're going to have to answer that question many times in the future, but I couldn't think of a better answer. Lisa, I don't know if you agree?
I can't even improve upon him.
Excellent. Okay, well, we come back later on and we'll have a discussion between all of us. And again, anyone who wishes to put in a question, please use the meeting chat and I'll be happy to put it to our speakers. Our second speaker is Sarah Casserly-Feeney. Sarah is a clinical specialist physiotherapist, currently the lead physiotherapist for planning and performance at the MSK initiative on behalf of the clinical care programs in rheumatology and trauma and orthopedic surgery. So, Sarah, we're looking forward to hearing from you. Sarah, you might be mute.
I'm unmuted. Am I okay now?
Perfect. Thank you.
Perfect. Okay. I'm just going to share myself, so bear with me for one moment.
Sarah, that's good, but you're mute again. There you go.
Yeah, perfect. Okay. Can I just clarify there, Ronan, are you seeing the slides?
I'm seeing the first slide. Yes, your introductory slide. Okay.
Perfect. Okay, so thank you for the introduction. My name is Dr. Sarah Casserly-Feeney and I'm a clinical specialist physiotherapist whose current role is as the lead physiotherapist Analyst for Planning and Performance of the National Musculoskeletal Initiative. And I'm really excited to have the opportunity to present at this seminar this evening regarding the future look of surgical teams. And I guess in particular, my role and the role that I represent is part of the orthopaedic surgical team right now. Out of interest, I would be interested to know how many people are familiar with the MSK role, because it's available in 18 of the sites across Ireland, of the acute sites. So what I'm hoping to do is, I suppose, present to people where this role has evolved from, how it emerged, and what the future looks like for us. Okay, so the MSK, the history. If I just move to the next slide, MSK disorders affect 1 in 4 of our population, so they account for 25% of an ageing and growing population, and as such represent a significant proportion of the GP caseload and that onward referral for services, including physiotherapy and surgical care.
Sarah, we're not seeing the next slide. Have you advanced on your screen?
I have. Let me just see why that isn't. Apologies, because I tested this earlier.
Pauline, do you have them?
I do, Prof, yeah.
Okay.
If you take them down, Sarah, thanks.
Okay.
Sarah, if you take down your screen share, we can do it from the college.
Okay. Okay, thanks, Pauline.
Thanks, Pauline.
Thank you, Pauline. Okay, so next slide. Perfect. So the MSK disorders, so musculoskeletal disorders, affect about 25% of the population, and I suppose with our growing and aging population, this number in its rawest form is increasing. And with this, the impact on the referral from our GPs to the surgical orthopaedic waiting list was increasing. And unfortunately, due to pathway development over the years and a poorly resourced primary care service in terms of physiotherapy, many of the patients on existing orthopaedic waiting lists were there with inappropriate surgical needs. And by that, I mean that the majority of these patients maybe weren't ready or did not need surgery, and effectively were waiting to get through to see an orthopaedic surgeon to be referred back out to the community for physiotherapy. So that inefficient musculoskeletal referral pathway led to a waiting list crisis. And at the times of the development of the clinical care programs, this crisis was recognised and a solution by way of the MSK triage initiative was developed. And I know this is a surgical presentation today, but I need to acknowledge that this is a hybrid initiative across 2 national clinical programs, so one being the rheumatology care program and the other being the orthopaedic care program. And the split within that would be about 80% orthopaedic to 20% rheumatology. And how this works would be that when a GP does now refer a patient to an orthopaedic or a rheumatology waiting list, the consultant triages that referral, and if they feel that the patient would be best seen by the clinical specialist physiotherapist, that triage takes place by the clinical specialist physiotherapist. And in general, that cohort of patients would be non-surgical, with non-surgical needs or appearances on referral in the orthopaedic setting, or in the rheumatology setting, those patients that don't appear to have an inflammatory presentation. Now, should it emerge that the patient has a surgical or an inflammatory presentation, dependent on the service, the patients are then referred acutely through to the surgical waiting list as required. And I suppose the ultimate aim of this is a patient-focused service where you strive to have the patient reach the right service and the right clinician at the earliest possible time. Sounds great on paper, and we are and have made great headway, but there are ongoing challenges regarding the management then of those non-surgical and non-inflammatory patients with musculoskeletal disease. And by that, I guess we need to look at workforce planning for primary care, HSEP, so even beyond physiotherapy, we need to look at occupational therapy and so on and so forth at community care level. And also the poor integration that has historically been in place between that primary and secondary care interface, and both at the levels of access to accommodation, resourcing of staff, and access to IT components, you know, the checking of investigations and so on and so forth. But all of this is something that has been, you know, looked at present and form part of the work streams which I am involved with. Next slide, please. Okay. This slide just references the ongoing and increasing trends. So despite the fact that we now have the guts of 30 MSK physiotherapists across Ireland helping to work on the existing orthopaedic and rheumatology waiting lists, this is also in the face of a 6.4 increase per annum on rheumatology referrals and a 9% increase in orthopaedic referrals on a year-on-year basis. And I suppose projections on this would account that we are looking at the potential of 230,000 patients sitting on orthopaedic and rheumatology waiting lists by 2027. In the past, our figures have shown us that around 40% of those patients, somewhere between 40 and 60, but we'll say 40% for a lower estimate, probably should not be on those waiting lists, and that's the cohort of patients that are suitable for the MSK clinical specialist physiotherapist. Next slide, please. I alluded to the fact that this is a hybrid initiative with the National Clinical Care Programme in Orthopaedics and Trauma and Orthopaedic Surgery and Rheumatology. And it also involves membership and involvement from the Irish Society of Chartered Physiotherapists, which is a professional body for physiotherapists in Ireland, and obviously the National Clinical Programme, so the collaboration there between the RCSI and the Royal College of Physicians. The map on the right identifies the 18 sites across Ireland where this service is currently delivered. And this slide is used again in a moment when I show where we are now and where we hope to go. So if I'd move to the next slide. Thanks, Bonnie. So in the initial provision, we had 24 whole-time equivalents delivering this MSK triage service at those 18 sites nationally. In 2017, there was the appointment of a planning and performance physiotherapist, which was myself at one point and shared with another colleague, Aisling Brennan. We would have business cased based on the data that we collect and the information that we have regarding the activity at the sites, and we're successful in attaining a further 6 posts, which were sanctioned in 2020. So at present, we have 30 whole-time equivalent clinical specialist physiotherapists in these 18 sites, and right now we have 2 outreach sites. So merging out from outreaching from the acute hospital sites to level 2 hospitals in this instance. Most recently, a further business case has been successful in securing 35 extra posts. And the vision here, these posts are not in place right now, but are in the process of being recruited. So it's a very exciting time for this initiative. But the vision here would be that while the 18 sites, acute sites, remain the sites for clinical governance, the delivery of the future of this MSK initiative would now move to be community and primary care based, and really, meet that need in terms of integration in its truest sense. So you'll have a conjoint service where the clinical specialist physiotherapist may work a day or 2 a week on the acute site, but then also deliver services off-site with primary care colleagues to really try and embed that service and streamline the pathways from the acute to the secondary care and back out again. And I'm really excited about this, and that's something I'm happy to answer questions on at the end, if appropriate. Next slide, please, Pauline. So just in terms of this slide, I've mentioned the 18 acute sites, but there are, as you can see, a number of black holes maybe up and around the Cavan Monaghan region, in around the Midlands and Longford and Westmeath. So by virtue of the outreach services, we hope to eliminate this black hole scenario for those patients with musculoskeletal presentations who attend their GP. Next slide, please. I mentioned the use of monitoring of activity and KPIs, and that's something that's very integral and has been very, very strong at the core of the development of this MSK steering group and initiative. So we have 4 baseline KPIs. The first KPI is the recording of the number of new musculoskeletal, orthopaedic and rheumatology referrals that are seen by the whole-time equivalent. And the target for that first KPI is 900 new patients assessments per annum per whole-time equivalent. The second KPI is a percentage regarding a ratio between the new to review activity of that clinical specialist physiotherapist. So effectively, because this is a triage and a new patient initiative where the focus is on the triage of those new patients, there is some capacity for review attendances, which we try to cap at about 10%. So the ratio here would be 9:1. KPI 3 then relates to the length of time, so waiting time for new patients to be seen. And the target here would be that 70% of new patient referrals to the MSK services would be seen within 3 months. And KPI 4 is the percentage of DNA, and the target here would be less than 12%. Okay, and these are the indicators that I would monitor. I collect that data on a monthly basis, and we provide then quarterly reports back to the sites, both through their MSK physiotherapists and to the consultants on those sites, to help manage the service and to act regarding quality initiatives as and if required. Next slide, please. The type of data that we generate, I've boxed out here now the 18 sites, but this is the type of information that comes to me on a quarterly and an annual basis to support us in the review of the activity that we're undertaking and ensuring that it's been delivered and that targets are being met. Next slide, please. I suppose I just wanted to flag the impact of COVID on the delivery of the service. So it's something that's very topical at present, and I guess, you know, we're not going to go back to what was before, regardless of COVID and how well we tend to manage it. I think our services are going to change, and specifically by that I refer to the service delivery in terms of telehealth and the blending of face-to-face and telehealth as part of our service delivery. So I guess in Q1, so highlighted in green, we'll see where normal activity was in existence, and then in red where no activity or very, very limited activity was in place due to the shutdown of outpatients, which ultimately almost decimated our outpatient activity, both at clinical specialist and consultant level for outpatients. In Q3, beyond July, we had started to resume the MSK service with predominantly telehealth activity, now more so in rheumatology, if I'm honest, than orthopaedics. And by Q4, all of our sites, apart from one, had reactivated their MSK triage service with a blend of face-to-face and telehealth service delivery. And I suppose nationally, we found there was a 30% complete loss of activity for 2020. With the reopening of services at face-to-face, we find that there's probably more than 60% potential loss for activity, so hence this need for that blended approach going forward. And the first quarter data, which I haven't analysed fully yet and couldn't do it for today's presentation, but we'll have it in the near future, will reflect that, because we have updated our data sheet collection tools to reflect the telehealth and the face-to-face components and how that is evolving in terms of efficiency, because we know what the numbers are, but we want to ensure whether or not it's actually efficient and effective for the patients in getting them to the right place at the right time. Next slide, please. So this is just a little bit in terms of the impact that we have had on orthopaedic and rheumatology waiting lists since our inception. So if we look to the very right of this slide, and you'll see an asterisk, and that's just because the 2020 data awaits final verification. But since 2012, the MSK initiative has seen in total 130,000 new attendances, but has been responsible for 20,000 reviews. 27,000 patients have not turned up for their first appointments, and following a contact have then been discharged from lists for a number of various reasons. But with this, we have 160,000 patients that have been managed and discharged from orthopaedic and rheumatology waiting lists. So I think that's very commendable. It also means that the number of these patients have not had to be seen by orthopaedic or rheumatology consultants, therefore allowing them to get on with the tasks that they want to do, i.e. surgery or complex patient management, or the management of inflammatory patients in the rheumatology setting. Next slide, please. Okay, this is just a brief or a graphic presentation of how we reflect the data back to our clinicians to help them see where they sit across the national picture and how far they are off or at the target. Next slide, please. This slide, I guess, is the most up-to-date and verified data that we had to present for you today, which would have shown the numbers that had been removed up to the end of 2018/19. But as I've said, 160,000 would have been the end stage figure in 2020 for the number of patients removed from waiting lists. What we can claim is that the waiting list would have been 130% greater in the absence of this initiative, and I think that's commendable, and it's probably reflected in the business casing for the extra resources to support this initiative going forward. Next slide, please. Okay, just in relation, and I guess this is going to be something that's reflected across all of our services. We've had to update and revise how we collect our data due to the the rapid implementation of telehealth services. And what we're very seriously looking to examine now and explore would be the outcome data from our telehealth consultations. And by that, we are starting to see a trend for an increase in the number of reviews following a telehealth consultation where the patient has to convert to a face-to-face. So we're just exploring the different possibilities about how we model the delivery of a blended service going forward. And with that in mind, we've obviously had to revise the quarterly and annual run sheets for the service and the data that we reflect back to the sites. We've also included greater depth regarding the outcome data from the various streams and the physiotherapy onward referral as part of that outcome data. And that will help to inform how the resources that we now acquire will also be deployed as we move forward into the post-COVID era. Next slide, please. Okay, so I've mentioned the new posts. I've mentioned the need to move forward with integration and I guess in line with Sláinte Care. So this infographic here on the right demonstrates the GP. On the red line would have been referring directly to the consultant initially. The blue line then shows us that these patients, some of those can be moved across to MSK physiotherapy triage, and I've identified what those figures have been. As we move forward, the green areas would look towards the movement of the MSK physiotherapy triage service much more to the community, but with embedded links back to the consultant so that we can truly develop an interface care type model where those patients are being moved to the right service much earlier, but with rapid and fast access back to the consultant should symptoms evolve or emerge. What we don't want to do is move everything to community and then find that patients who should have had surgery are now not getting to that service faster. So we need to ensure that we cover all of these possibilities in the development of these specialist HSCP pathways at primary care level with clinical governance delivered from the acute care setting. Next slide, please. Now, Pauline, if possible, and you click on an infographic there, it will show. No, that's fine. What I can do is I can share that infographic afterwards for anybody who wishes to see it, and it's just a history of the musculoskeletal initiative and various pieces of research we've done even with patients. So finally, I'd just like to acknowledge the working members of the MSK steering group, and they include, as I said, the orthopaedic surgical leads, who are Mr. David Moore and Mr. Paddy Kenny, and the programme manager for orthopaedics, who is Catherine Farrell, and soon to become Paddy Kenny. And the other members who feed into that group are named there as well. My email contacts and my phone number are also there if anybody would like to contact me or like to clarify any part of this presentation. Thank you.
Sarah, thank you very much. And we will move on to Jamie Logan and come back to you then for questions at the end, if that's acceptable. Jamie, we're looking forward to hearing your presentation. As I indicated earlier, you're the National Nurse Lead for the clinical programs, and we look forward to hearing what you have to tell us.
Mr. President, thanks very much for the invite and the opportunity to speak here this evening. You should be able to see my slides.
Yes, we can.
Yeah, I just can't see them myself now. Just 2 seconds, sorry. Are they moving for you?
Yes.
Yeah. Okay, so thanks everyone for the opportunity and to come here and speak this evening. As I've already been introduced, my name's Jamie. I'm the nurse lead with a national clinical program in surgery, and I'm here to talk to you today about the journey towards advanced practice in nursing and their role within the surgical team and the models of care that underpin and support their rollout incrementally nationwide. So for those of you who don't know, a quick definition for a nurse in an advanced role is somebody who performs at a higher level of their capabilities and their scope of practice as an independent, autonomous and expert practitioner who, with the support of a clinician there, namely a surgeon for clinical supervision and underpinning professional development, is able to practice autonomously, as I say, at that higher level of capability. This is all underpinned by a model of nursing there from the NMBI that they produced back in 2017. And as talking to the president earlier on, we both alluded to the fact that there seems to be a lot of steps to get to advanced practice. And as you can see from this diagram, there are a number of steps there, both locally organising the MOUs and the SLAs for the specific cohort of patients that a nurse will see, down to the clinical supervision by the consultant there, which is about 500 hours clinically, and really ironing out all of the referral pathways, the governance, the accountabilities, the underpinning, PPGs to support the nurse to enable them to get to that level of higher practice and the higher level of capability, providing that patient-centered, person-centered, evidence-based practice there for nursing. So that's the kind of background of the ANP, and I think it would be interesting to look where we are nationwide in terms of numbers. So in Ireland as a whole, there are 477 registered advanced nurse practitioners throughout all specialities, which is including 14 advanced midwifery practitioners. And then there are additional 175 who are on their journey to becoming a registered advanced nurse practitioner, carrying out all of those steps to become registered by An Bord Ultranis, including 21, again, advanced midwifery practitioners. And this is just in the HSE funded hospitals. This isn't including the private sector. And the numbers is another 100 there in private practice. So taking it up to nearly 600 of 577. So I thought it would be interesting to look how some specialities that have had a very successful journey with the rollout of advanced practice got there. So one of the success stories is the emergency medicine program, and this information has been supplied to me by the nurse lead from the emergency medicine program, Fiona McDade, who tells me that their journey started back in 1996, where they had the first ANP registered in emergency medicine. And whereas now they've got a head count, not whole-time equivalents, but they've got a head count of 140 advanced nurse practitioners within the emergency setting and injury units throughout the country, both registered and candidate ANPs there. And they're delivering a very succinct pathways of care, independent nurse delivered care within injury units, rapid assessment and treatment, and then the Home First service, which is about the homeless and the frailty service, delivering that at the front door of ED for the kind of admission avoidance piece. Of course, as all services have in recent history, there's been challenges with COVID, and in the first wave we saw an awful lot of nurses in advanced roles being redeployed elsewhere in the hospitals. And as we alluded to earlier, there's so many hurdles to jump through to become an advanced nurse practitioner. There is a certain reluctance by certain staff members to go down the training route because it's so long and protracted, but still they've managed to get so many nurse practitioners in emergency medicine. And Fiona tells me that the aim for emergency medicine program is for injury units to become advanced nurse practitioner led in future years. Again, if we look at acute medicine, again, a successful story where the AMAUs are primarily nurse-led by advanced practitioners there. They had their first 2 candidates back in 2017, and they were they benefited from the Department of Health demonstrator project that awarded an additional 23 advanced practice posts to AMAUs. And these, again, are providing very specific pathways of care in headaches, DVT, cardiology, and the ability to discharge patients to follow up from the advanced practitioner. And in 2021, we've now got probably around 30 nurses who are either on their journey to or registered as an advanced practitioner in acute medical assessment units. Again, we've had challenges with COVID, with AMAUs closing down over the last 18 months as a response to the pandemic. And one of the main problems there that Richard Walsh, my counterpart in the acute medicine program, tells me is some additional challenges around requesting advanced diagnostics through radiology for DVTs and MRIs, which currently ANPs aren't authorised to do so on behalf of their consultant teams. And in terms of the aims from the acute medicine program, they want 12-hour cover in all of their AMAUs 7 days a week by advanced practitioners within the coming years. So where are we in surgery? It's a fairly sorry story if we remember we've got 477 nurses in advanced roles nationwide. Our surgical advanced nurse practitioners represent just 4.4% of that entirety of advanced practice. So 21, the biggest hitter is thoracic surgery, followed by urology and plastics there. And there are a number of reasons for this, mainly, and listening to Sarah's presentation there with the waitlist reduction piece from the advanced clinical specialist physiotherapists. With the nurse practitioners, it's very difficult for them to reduce waiting lists. They're improving quality of care, they're having high rates of patient satisfaction and completing episodes of care, but proving that kind of waitlist reduction piece, which is obviously where the money follows in terms of funding for roles, is a challenge. So what is the future for advanced practice in nursing? So from a clinical program point of view, we're trying very hard, and in my role, I'm trying to advocate the role of advanced practice throughout all of our documents that we're producing. One of our main work streams is the acute surgical assessment units, which is all about getting timely access to a senior surgical decision maker as close to the front door as you possibly can. Now, historically, this had always been a surgeon, whereas we're quite keen that this could be somebody of a differing role, so that we've defined this within the current standards for the acute surgical assessment units as a member of staff of either ST3, ANP or equivalent role, which incorporates the physician's associate, who's importantly empowered to make a decision on admission or discharge on behalf of the team. In terms of other models of care that we've recently published as a program, the urology model of care, and I'll make no apology that this is going to become a very busy slide, which shows how embedded advanced practice is within urology. We believe that an ANP in urology can do a number of different things. We can see over in Salter Group that there's been strong strides made with the lower urinary tract symptom in male advanced nurse practitioner led service. We believe that there's a role there for advanced practice in the treatment of stone disease, in voiding dysfunction with children, in erectile dysfunction. The list goes on really in urology for advanced practice. We also believe that they've got a key point in the promotion of continence out in the community, in line with Sláinte care. We believe that in line with a women's health physio, an advanced practice community care practitioner could promote continence rather than treating incontinence. And we see examples of this over in Roscommon and elsewhere throughout the country. And we also believe that advanced practitioners have a role in the surveillance of bladder cancers and prostate cancers for the cancer treatment, carrying out cystoscopies under for surveillance patients of bladder cancers and managing the PSA surveillance follow-ups for the prostate cancers. We also believe that advanced practitioners can be central to see and treat models of care. So urology has really grasped this notion of advanced practice, and whilst we only have 3 urology nurse practitioners at the moment, additional funding has been granted as a result of the model of care to increase that number up to 7 nationwide, which is fantastic. In other specialities, otolaryngology, head and neck surgery in the model of care for Ireland that was published a couple of years ago now. There's a number of different roles for advanced practice in the unscheduled delivery, the outpatient setting, and as well the role for scheduled care advanced practice for discharging, and Aaron's piece earlier about facilitating early discharges from the acute hospital, all central to the otolaryngology head and neck A&P. And we've suggested within this model of care some recommended KPIs there about decreasing waiting times, about fewer readmissions and fewer review patients. But like we've alluded to, this is not waiting list cutting, this is improving a quality service for patients and the teams. The programme are currently writing 3 further models of care. For vascular surgery, central to this will be the role of advanced practice for tissue viability, for diabetes, for the vascular advanced nurse practitioner, again with plastic surgery, another model of care that is currently in draft format coming out, hopefully within the next few months to early next year, where the role of a plastic surgery A&P delivering see and treat models of care is central to the model of care there, and similarly for the oral and maxillofacial surgery model of care, which again will be coming out early next year. So in summary, advanced practice isn't a quick win because it's supported by appropriate training and experience. It's not a quick journey to being an A&P, and we can't just say let's employ 50 A&Ps from tomorrow, because there's a journey they will need to take to incrementally become registered advanced nurse practitioners. And as we've alluded to, there's some challenges around the funding there. However, we are on a journey within surgery to support the rollout of advanced nurse practitioner, which is underpinned and driven by the models of care from the surgery programme, supported by appropriate clinical practice supervision by their peers and consultant colleagues, and underpinned by appropriate governance. I look forward to the discussion that will follow, and thank you for your time.
Thank you, Jamie. And it really is looking like the clinical programs are beginning to be resourced and to beginning to change practice as we would hope. Can you just, and it's my ignorance, just explain the difference between a clinical nurse specialist and an advanced nurse practitioner?
An advanced nurse practitioner will be able to carry out a whole episode of care for a patient, whereas a clinical nurse specialist will be performing at the kind of specialist level rather than the advanced level, but will be in addition to a team, whereas an advanced nurse practitioner has got that independent, autonomous element to their role.
But the advanced nurse practitioner can't prescribe or order ionizing radiation.
There are some challenges with the radiation prescribing. There is a limited list of X-rays and diagnostics that the advanced nurse practitioner can prescribe, but it's the advanced diagnostics there, the CT, the MRI, the Dopplers, which are outside their scope of practice and need to be done by their medical colleagues.
And just to tease this out a little bit more, I mean, would we get more bang for our buck, so to speak, if we increase the numbers of clinical nurse specialists rather than advanced nurse practitioners? I only mean because of the very long training process for advanced nurse practitioners.
I think that clinical nurse specialists is, as we were talking earlier, Ronan, every good surgeon has a very effective nurse specialist following them and delivering their service on their behalf with them. The difference between specialist practice and advanced practice is the advanced practitioner will be leading their own team of work with a specialist nurse behind them as well. So they're really performing at that higher level of practice from a nursing point of view.
There's a question in: can a PA prescribe medications and request investigations? Lisa or Aaron?
At the present time, there are no regulations that would facilitate that role for PAs or that scope of practice, but I can tell you that in the US, we have prescriptive privileges in almost every state, can request and order all types of diagnostic studies. I know that in the UK right now, they anticipate that once regulation is formally finalized, which they anticipate in 18 months, that prescriptive privileges will follow.
And this will be with the GMC?
Correct.
And in terms of professional regulation here, will we be looking to the IMC or will we be looking to another body?
Right now, I believe the Irish Society of PAs are advocating for the IMC.
Okay, okay. Just Patrick Sheehan has come in to say one issue with A&P in some specialties, for example, head and neck, is that their greatest ability is to see return patients, whereas funders, for example, HSE, are really only interested in funding roles that take new patients off waiting lists. Any thoughts on that?
Yeah, I think when we look at the funders' priority, of course, we're wanting to reduce an ever increasing waiting list that is gone through the roof with COVID and everything else that's going on at the moment. Whereas the advanced nurse practitioner has really got the ability for that quality service, and as Lisa alluded to with the physician's associates there, it's the continuity of care, the better care, that they will be stagnant within a team, not stagnant, static within a team. Wrong word there, stagnant. Static within a team when there's so many changes within the staff going on. So I think it's about delivering that better quality for patient care. But I completely agree with Patrick that this is one of our greatest challenges, and it's how we overcome this.
Which brings me to Sarah, and I mean the triage role. This is really, to one extent, weeding out inappropriate referral and redirecting it.
Yeah, and I guess in terms of all that you've alluded to there, okay, so within the triage roles that have been designated, the actual job description is both to see and treat, and I guess that's what makes the physiotherapist attractive in the MSK perspective, because they're triaging the list, but then they're also managing those patients that are inappropriate, as opposed to just shifting that waiting list somewhere else to await further management from somebody else somewhere else. So I suppose with the skills that the clinical specialist physiotherapist has, they have the capacity to autonomously, and that's a slight difference between the clinical nurse specialist and the clinical specialist physiotherapist, would be the autonomy of the clinical specialist to assess and treat autonomously at that level, and to then take that patient and manage the episode of care to its conclusion. So we see, assess, treat, diagnose and discharge with the support of the consultant if required, but often without that patient needing to see that consultant at all. And I would agree with Jamie, there are some, like, this could be better. I mean, we don't have ionizing prescription rights. We don't have prescription for medical rights. So while we can deliver and administer injections, we cannot prescribe those injections, which, is something that we're currently working with the ISCP and with Minister Stephen Donnelly in relation to legislation that's required just to navigate that space in terms of advanced practice. But I guess the thing that really helped to fund and to secure the funding for the extra resources would have been the capacity to not just assess and triage, but to also treat and manage. So all of those jobs have a treatment component as well. And I, along that line, Jamie, you alluded to the capturing of data to reflect that. So I suppose we would have captured an awful lot of qualitative data alongside that really quantitative KPI, because I mean, KPIs are useful for looking at our service delivery, but they only tell part of the picture. They're black and they're white, and they don't tell what's really happening. Was it a good service? Was it effective? Did we just shift a waiting list somewhere else? So that qualitative data is really, really important, along with site visits. And I work as a liaison for the clinicians on the ground to try and support them in ensuring that everything is as effective and as streamlined as can be. And it's not always perfect.
But we have just on that, it was one of the things I was wondering about with all these KPIs. I mean, at the end of the day, it's patient outcome measures, their satisfaction. So do you have any of these PROMs, patient-related outcome measures?
So we would use both clinical patients, so patient-related outcome measures just at a clinical phase, but also those patient satisfaction measures. So they've been collected over the years. Every 2 years we present that patient data, and along with that, the other stakeholders who we would survey would be GPs and the community-based advocacy groups. So the likes of Arthritis Ireland and the other groups that are really important in maintaining the service for the patient, because at the end of the day, we are part of a journey for that patient. We are not, we are a point in a journey. And if we make one change, that has a balancing impact somewhere else. We need to be aware of the knock-on impact of us at every point along that pathway.
I mean, one of the things that really is a difficult problem in our health service is our reliance on many young doctors who are not on training programs.
Yeah.
How can your collective input ameliorate this problem?
One element, I'll take that first, because 2 weeks ago I was asked to present to GPs who are on a GP training scheme. Now I know that's not exactly the group and cohort that you may be alluding to, but the model is effectively the same. But that would have been to share our expertise in terms of MSK assessment with that group of GPs. So I always offer that service when I'm in clinic, that they can come and rotate through our service to see that on the ground, to supplement the online learning that I've done with those clinicians. And these are the clinicians of the future. So it's really important that we embed right now so that they will also have access to see the different models of working and the different team and its entirety. And I think that's really, really important that we do that. And with the AMPs that I work with in rheumatology and in orthopedics, we would have collaborative training sessions. And I guess
that's training people who are on training programs. And I remember back to when I was doing my fellowship in the States and actually rotating with the stoma care nurses and rotating through different disciplines was hugely beneficial to my training. But what I'm getting at is whether or not advanced nurse practitioners or indeed PAs can actually start to help reduce this over-reliance on people who are in fact not on training programs. Jamie, Lisa, any thoughts?
Yeah, I think that, being a static member of the team there is hugely beneficial, as we've all touched on today. And I think that there is absolutely an opportunity for advanced practitioners, for physicians associates, for specialist physiotherapists to be there filling those gaps, but not just filling the gaps because we can't get them from anywhere else, because it's a development of the service and a development of all of our professions, which is at the core of the service that we're all trying to deliver here. And I do think there absolutely is a teaching and learning and research and audit part to all of our roles here that we're advocating for. And could we educate some of these non-training doctors into the practices and models of working? Absolutely. Yeah, I think there's a huge potential there.
But we have nearly 60% of our NCHDs are not on training programs in surgery. And so the issue is, can they be replaced by PAs and advanced nurse practitioners, particularly in terms of the on-call commitments and 24/7 cover?
I can only reflect on my experience as a surgical PA. My first position, as you know, in the U.S., the residency programs are supervised by the graduate medical education accreditation process. And in the late 70s, early 80s, there was a diminution of residency programs at local community hospitals because of the caseloads, the numbers, the frequency of surgical residents being able to participate in surgical care. So when these hospitals lost their residency programs, they opted to employ physician associates in those roles. And it took a while for the hospitals and the attending consultants to adjust. But you will see that the PA profession is quite nimble. They're trained in the medical model, and they are very fluid as they look at filling slots within a health system. So I can't say what the outcome would be. These are high-level policy decisions for folks in the Ministry of Health, but PAs would be very interested in pursuing some of those discussions.
Thanks, Lisa. There's a comment from Emmett Cullen who says, in reality, does the ANP remove the longest waiters from a waiting list, moving those patients further away from the appropriate point of care required by a specialist?
Interesting. I think that some of the roles that we've talked about today in advanced practice are there for diagnosis, are there for quality, are there for discharge from the acute hospital. I think there are examples where an advanced nurse practitioner, along with other members of their MDT, will be filtering out the longest waiters and potentially referring on to other services. But I think that this is an interesting comment and one that probably needs a further think about.
Yeah.
Well, I think the truth is that they will do some of that, but really, if it's really once you start unblocking the logjam and creating pathways that are facilitated by ANPs and PAs, then the whole process just becomes more streamlined. I dread to think what faces us once we get over the COVID. In the UK, there's something like 5 million people now awaiting a consultation or a procedure, and if you add everything up here, it will be close to 1 million.
Yeah.
Anyway, I think we've had a very interesting discussion. I have no doubt that this is the way forward. It is really good to see what is being generated out of the clinical programs. And I'm talking about the clinical programs in surgery. Sarah, you're dealing with it in trauma and orthopedics and in rheumatology as well. But eventually we're beginning to see progress. I think there really will have to be regulation of PAs. There really will have to be an extension of prescribing rights and request rights for ionizing radiation. I mean, it beggars belief that an intern coming out of medical school actually has greater prescribing rights than somebody who is an advanced nurse practitioner. I see Arnie Hill has appeared, and Arnie, your hand is up. You're welcome.
Yeah, thanks, President. I just wanted to make a point. It's interesting hearing the discussion. As you know, we've adopted physician associates and been strong supporters of that. And in the breast service in Beaumont, it's just key to us. We couldn't exist without them. And as you know, many of the other asymptomatic units have also done this, and it's been a very successful integration. So any service that has high volume, repetitive clinical practice, such as in orthopedics, in vascular, where you see varicose veins, in breast, where you see high volume patients, done in the appropriate fashion with appropriate supervision. We've actually published on this. They're invaluable to us. And I would encourage people to think outside the box. I also support ANPs. They are incredibly useful. The health service is very diversified. Many of our symptomatic breast clinics are bringing in GPs to work with we've 42,000 women being referred to the symptomatic services in 8 centres each year. Now, 10 years ago, there were only 13,000. So we're seeing an awful lot more, and we need to appropriately get the right people to see them with the right support and the right supervision. So I would just encourage people, think about your service. How can you make it more streamlined? There's a huge role. We're only just starting. And in fact, our problem is we aren't graduating enough PAs, and that's something that we hope will happen over the next 5 to 10 years, because every hospital should have more, both PAs and ANPs. And we need to think about how we deliver our service. You know, the single consultant can't see all of the 10,000 breast referrals each year to Beaumont Hospital. And people need to be realistic about that. In relation to the comment about the physiotherapists, I know Hannon Mullett runs his clinic opposite me, and there's always a physiotherapist seeing new patients, diagnosing, treating the challenging back, or the repetitive practice in that service. So, you know, I think we all just got to think outside the box, and it's about using different disciplines to run your service better. We have been totally impressed by the PAs. We couldn't do without them now, and it's the same for many disciplines within Beaumont. So I would just encourage people to think outside the box. That would be the main purpose of today's webinar, to let people realize they are fantastic professionals. They are really a pleasure to work with, and I would encourage everyone to think.
Thank you very much, Arnie.
Thank you, Arnie.
One point, that's fantastic. The comments you've made there are just so enlightened, and thank you so much. And I guess one point just to add to that would be that in evaluating your waiting list, it's really to evaluate the escalation, like where are the pressure points, and what are the patients on your waiting list, what are the needs, and then to apply the services effectively. So that's, you know, just echoing what you said. And we found that those longer waiters are those patients with chronic pain, different needs, non-surgical needs, non-inflammatory, but it's about getting those patients to those correct services at a much earlier time on their journey. So yeah, no, thank you.
Good. Well, congratulations to you all for the success so far. And thank you, Arnie, for coming in and bringing that message of support. I think undoubtedly the surgical team 5 to 10 years from now will be very different from what it has been for the last 100 years, and we look forward to that. Thank you to all our speakers. Thank you to all of you who have joined in. We had, I think, about 120, 130 people on the line this evening. Others will watch the recorded version. And I wish you good evening, and we'll see you next week.
Thank you.